So while he's working, I have memorized some of the slides, so my memory is okay. But so I wanted to talk a little bit about memory loss and what is dementia, what is normal aging, and this is a common complaint that I get when someone comes into the clinic. So for an example, a 65-year-old woman comes in to see me and says that she has problems with word finding, sort of thinking of the right word to describe an object. It's at the tip of her tongue. Is that normal? She's forgetting parts of conversations. We all do that. Is that normal? So a common question is this normal aging? Oh, thank you. Is this dementia? Is this Alzheimer's disease? So let's define a few of these terms. Well, dementia is defined as a cognitive impairment, so that could be memory loss, but it could be language problems, it could be navigation problems that causes a functional disability. And a functional disability would mean that you can't work anymore. You're having trouble paying your bills, you're having trouble cooking. In an advanced setting, you might expect that to be trouble bathing, trouble feeding yourself. So there's a spectrum. Mild cognitive impairment is another term that we use that means that you do have a cognitive change, so problems with memory, but it doesn't impair functional ability. So you're continuing to be able to work and do your daily routine, live independently. So the difference really is the severity. And Alzheimer's disease is a type of dementia. So think of dementia as an umbrella term, and Alzheimer's disease is the most common one, and people tend to associate the two. So how do we determine what is the severity of someone's deficits, if they have any? Well, cognitive or neuropsychological testing, where we do memory tests in the clinic, or a neuropsychologist might do that, can help determine where you fit on that spectrum compared to other people your age and educational background. Asking family and close friends is what I often do in the clinic to see what the functional ability is. Are you still working? Are you paying your bills on time? Are you remembering to take your medications? Other things that we might think about doing would be a brain MRI or CT scan, getting a picture to know what's going on in the brain, to rule out other treatable causes. Maybe there's a tumor, maybe there's a stroke, maybe there are other things that are contributing to these changes. And blood tests would also be incorporated to make sure that we are ruling out some thyroid changes or B12 deficiency that might cause cognitive problems. So a few facts about Alzheimer's disease. It's the most common type of dementia, as I mentioned. That's why people tend to think about it and equate it with dementia. But 1 in 9 people over the age of 65 have Alzheimer's disease, and 1 in 3 over the age of 85 have it. So it's really a staggering number as you age. Over 5 million Americans are affected, and it's the 6th leading cause of death. And if we look at this graph on the right, between the years of 2000 and 2010, breast cancer, prostate cancer, heart disease, stroke, and HIV have all decreased in number of deaths. But Alzheimer's disease is continuing to rise. And if we look at our population prediction of who's going to have Alzheimer's disease, if we say that now there are over 5 million Americans affected, by the year 2060, over 13 million Americans are going to be affected. And if we focus on women, well, of the people with Alzheimer's disease, 2/3 of them in America are women. Women are more likely to be caregivers. Makes sense. Out of the unpaid caregivers, 3 out of 5 of them are women. And 2.5 times more women than men are giving 24-hour care. 20% of women caregivers quit their job to become a caregiver. And if we think about the lifetime risk of Alzheimer's disease, in your 60s, a woman has a 1 in 6 chance of developing it, whereas breast cancer is lower at 1 in 11. So what are the risk factors for developing Alzheimer's disease? Well, we've heard about this as age. As I said, above the age of 85, 1 in 3, and I've seen some statistics at 1 in 2, so it's quite high. But if you look at the green, that's less than 65 years of age, it's only 4%. So we can't really help age, but that's the major risk factor. Genetics are another strong component. So family history. A lot of patients come in to me and ask, I have a family history, my father had it, he was in his 80s. I don't think that portends a higher risk. I think if we think about younger age of onset, that might be more of a stronger family history. But there's another genetic mutation in the apolipoprotein E. And the type of isoform, a type of mutation, there are 3 of them. ApoE4 increases that risk of developing Alzheimer's disease. We'll talk about that a little bit more. A history of prior head trauma can increase the risk of Alzheimer's disease. And vascular disease, it's great that I followed Dr. Chandra here. Vascular disease increases that risk. And low education increases the risk of Alzheimer's disease. So maybe just by being here today, we're decreasing your risk of Alzheimer's disease. And sex modifies that ApoE risk. So this is a study that came out in March by one of my colleagues. And I wanted to explain a little bit more if you hear about it. So ApoE, this genetic mutation that everybody has, you inherit it, one from your parent, another one from the other parent. It's a risk factor for sporadic, meaning non-familial Alzheimer's disease, and late onset familial Alzheimer's disease. They're one of 3 types that you can get. The E3 allele, it portends a neutral risk of developing Alzheimer's disease. ApoE2 is a lower risk, and ApoE4 is increased risk. So these are things we already know. ApoE4 is present in 50% of people who have Alzheimer's disease. But it's also present in 15% of people who are normal. So just because you have that allele doesn't mean that you're going to have it. So it's not something we commonly check in the clinic. But in research studies, we look for it because it's a higher presence in people who have Alzheimer's disease. What this study is showing us, though, is that women with this ApoE4 allele have 4 times the risk of developing Alzheimer's disease versus women with just the ApoE3 allele. But that risk is not present in men. And so they found that ApoE4 carriers are more likely to convert to Alzheimer's disease or from normal to mild cognitive impairment. And that presence is more in women than men. We don't understand why yet. So what are the common symptoms that we might expect if someone were to have Alzheimer's disease? Well, memory problems, that's what we tend to think about. So that's sort of forgetting conversations, misplacing things, repeating yourself. But other symptoms that we might hear about, trouble finding your way around, getting lost, word finding problems, organizational problems. But we have to hear that there's a progression over time and that there is a functional decline for us to give you that diagnosis of dementia. And what causes Alzheimer's disease? Well, if you look at the figures on the left, the normal neuron or the brain cell, we have, and you compare it to the one below, we have plaques and tangles. They're 2 proteins that build up in Alzheimer's disease. One protein called amyloid, and it forms these circular structures here called plaques. And then the other protein is tau that forms these tangles, or you see here, or these flame-shaped structures. And so they cause damage to the neurons, death to the neurons, and eventually then we start to see structural changes on MRI or imaging studies in which the normal brain is on the left. And this part of the brain here is particularly atrophied. That's the hippocampus. So if you can see here, the hippocampus means seahorse. So it's that curly Q shape. And it's shrunken or atrophied on the right in Alzheimer's disease. And the cortex, the surface of the brain, also tends to shrink or atrophy. So if we know how Alzheimer's disease develops, why don't we have a cure yet? Well, people have tried. So between 1998 and 2011, over 100 medications have been tried to treat Alzheimer's disease or slow down the disease or cure it. But only 3 have been brought to market. Some of these trials included targeting that amyloid protein, but they have failed. And one possible hypothesis is because we're treating too late. And so if you look at this figure on the right, this came out in 2010, and this hypothesis is now widely accepted, that the amyloid protein in red starts to build up. And over time, in blue, the tau protein then tends to develop. And over time in the green, structural chambers, or what we might see on the MRI, might then develop. And then in the purple, we start to hear about memory loss. And then in this, I think it's turquoise, then we start to hear about a functional decline or dementia. So by the time someone gets a diagnosis of Alzheimer's disease, it can be decades between that red to that turquoise. So by the time people were enrolling in clinical trials, maybe that amyloid protein, it's just too late to try to fix it. So people, pharmaceutical companies and clinical trials are now targeting patients who have earlier symptoms. But another potential problem as to why drugs have failed in the past is that we had the wrong diagnosis. 25% of people in these prior trials did not have these amyloid deposits or Alzheimer's disease. And basically, people were enrolled based on clinical symptoms, and that's what we had in the past. You hear the story, you think, okay, this fits with Alzheimer's disease. But now there are more confirmatory tests, such as biomarkers. So I mentioned that amyloid protein can build up in the brain, and we now have PET scans that can detect that. So here in the red, that's the amyloid that we see in the brain. We don't commonly do this in the clinic and order it as a PET scan, although you could, it's just that insurance doesn't reimburse for it. Another thing that we can do is look at the spinal fluid. So the fluid that surrounds your brain, surrounds your spinal cord, we can take some of that fluid in a little procedure called a lumbar puncture, kind of like an epidural. We take that fluid and analyze it for the amyloid and the tau proteins. And if that's consistent with that Alzheimer's disease profile, then we think that might be what's underlying and going on. But not all dementia is Alzheimer's disease. Although it's the most common, there's some other things that we need to think about. So under the age of 65, frontotemporal dementia is just as common as Alzheimer's disease, and it's called frontotemporal dementia because there's atrophy or brain shrinkage in the frontal lobes where that arrow is, and the temporal lobes. Lewy body dementia also accounts for 10 to 20% of dementia, and vascular dementia, where people have a history of strokes or small strokes, can develop, and that's also present in 10 to 20% of dementia. There are other rare causes as well. And I'll talk briefly about Lewy body disease and frontotemporal dementia. So Lewy body disease, although people can come in saying, I have memory problems, I have problems with organization, I have problems with navigation, and that is what you might hear in Alzheimer's disease. What's different about Lewy body disease is that we hear about some hallucinations, that they're recurrent and formed, such as small children, animals, people, usually not bothersome to the person. There can be Parkinsonism, meaning symptoms that look like Parkinson's disease, such as a stooped posture, a tremor, slowness, stiffness, and there are fluctuations in arousal, meaning that people can look dazed, confused, and at times look very lucid, cogent, that waxes and wanes throughout the day. If we have those symptoms, it makes us think more about Lewy body disease, which is different because in Alzheimer's disease, we have the tau and the amyloid proteins, but in this disease, we have a buildup of these what's called Lewy bodies that are made up of a different protein called alpha-synuclein. And there are other supportive features that might help us think about this diagnosis as well, such as people who, when they're sleeping, act out their dreams so much that they punch their bed partner, knock over their bedside lamp, fall out of bed. Or they might have sensitivity to certain medications, such as antipsychotics. So if the patient goes in, say, I have visual hallucinations to their primary care doctor, they start them on an antipsychotic for that, they actually get worse, which is unusual. One other type of disease that we talked about is the frontotemporal dementia, where it's very different, actually. People tend to have changes in behavior and personality. So apathy is a common symptom. Disinhibition, which is a very different personality from what you would expect of a typical person. Maybe they might be rude, call someone fat, which is not something they would have said in their prior, before the disease hit. They might say someone is ugly to their face. Decreased empathy. So say their spouse cut off their finger, said, take me to the hospital, I need to go right now. These are examples of patients I've had, but they say, no, I'm busy, I'm cutting the lawn right now. Compulsive behaviors. So that might be as simple as checking the locks over and over and over again, or it might be as extensive as I need to kill all these ants in the garden and collect them in a bucket and counting them, 1,000, 1,001, 1,002. So sort of this obsessive compulsive type disorder. They have an increased preference for sweets, gaining 20 pounds, or problems with executive function. You might hear that in just planning, organizing, or you might see that on some of the neuropsychological tests. And what's different on some imaging studies, besides the atrophy that you might see on the MRI and the frontal lobes, but on a glucose PET scan, we would see decreased metabolism in the frontal lobes versus in the parietal lobes in the back of the brain, which you might see in Alzheimer's disease. The proteins that you would see develop on pathology would be the tau protein also that you might see in Alzheimer's disease, but you don't see the amyloid protein. There might be in 50% of cases a TDP43 protein, or in a small percentage this other protein called fusin sarcoma. So if we go back to our patient and we think about, well, what sort of tests have we done for her? Can we figure out if she's normal or if she has dementia? Well, if she has no functional decline, does well on cognitive testing, then we think she's normal, at least right now. If she does have some problems on memory testing, but she has no functional decline, doing well, working, managing her household, she has what we would call mild cognitive impairment. But if she has both abnormal testing and a functional decline, then she might have Alzheimer's disease. A brain MRI or further imaging might help support these findings. So if we think she has Alzheimer's disease, what can we do for her? What treatments are available? We know there's no cure. There are some treatments available. Most of them that we have are in the cholinesterase inhibitor group, meaning we boost this neurotransmitter called acetylcholine in the brain that should help with attention and memory. And the reason why it got approved and why we try to use it is because it slows down the changes on memory that we might notice on neuropsychological testing. So if we look on the graph on the right here, this is a placebo group, and over here is the treatment group. So on memory testing, people sort of changed their progressive decline that you would expect in Alzheimer's disease. However, it doesn't change the underlying proteins or the disease. So if you stop the medication, you'd catch up to that lower graph. Memantine is another medication that we have approved for moderate to advanced Alzheimer's disease. But besides medications, what else can we do? Well, exercise. We all love exercise. Socialization, intellectual stimulation, it's all good for the brain. Sitting at home watching TV is not the stimulation that the brain craves. And to highlight exercise just a bit more, there have been several studies to show that it actually helps certain parts of the brain function better. So the hippocampus we've talked about, that's the part of the brain that helps you form new memories, and it's highlighted in yellow on the left figure. And so in a study in 2011 of 120 people, where 60 people exercised at least 30 minutes, 3 to 5 times a week, versus people who just did stretching. Well, we expect the hippocampus to continue to atrophy as we age, unfortunately, about 2% in volume per year. And so that happened in the people who did the stretching. But the people who exercised not only slowed down, but increased the size of their hippocampus. These are healthy people, but it goes to show you that extended the life of the hippocampus by a year or two. And so this has been replicated in younger people. This study was in 65 average age, but in younger people that's been replicated, and in people who have mild cognitive impairment, it's been replicated not in the hippocampus, but on memory tests and functional MRI. So it goes to show you, we don't know exactly how much exercise, what kinds to do, but aerobic exercise might help slow down the progression of memory loss. And I wanted to end with one study that might be exciting on the horizon. So this study has been reported in the New York Times, CNN, USA Today, and even on SNL, and that's where this video has come in. Let's see if we can get that going.
Scientists report that older mice were stronger and more active and alert after they were injected with the blood of young mice. 4 crates of baby mice, please, said Madonna.
So just as strange as that is, so this actually happened with young mice. So one of my colleagues took young mice and in this strange Frankensteinish figure connected the circulation between young mice and old mice, and then old and old mice, and found that the synaptic plasticity, so meaning the connections between the neurons of the brain cells and the hippocampus, were enhanced by that young blood. And then with actual just injections, so not, you didn't have to sew them together, but injections of young blood to older mice improved memory testing, suggesting that maybe there's something in the young blood that helps the brains function better. And this has been shown in other studies. That's why this has got a lot of press, in other studies by different groups, that there's some maybe factors in the young blood that help with older mice function. And so we'll actually be part of a study in the coming months taking Alzheimer's disease patient and infusing some young blood, not sewing people together, but just some plasma injections. So in conclusion, just a few highlights recapping, what are my chances of developing Alzheimer's disease? Well, unfortunately, age is a risk factor. So 1 in 9 people over the age of 65, 2/3 of which are women. But there are other factors such as genetic, environmental, and medical risk factors that might change, increase, or decrease. So let's think about exercising. And how will I know if I have Alzheimer's disease? Well, you can see a neurologist or your doctor for testing, imaging, evaluations. But to keep in mind, it isn't always Alzheimer's disease. It could be some other disease. And then what are the treatments? We talked about cholinesterase inhibitors, memantine, but really highlighting the fact that there are other things that we can do that might even be better than medications, such as exercise. So I wanted to thank you all for your attention today.